And this is settling all the debates in cataract surgery. So we have a lot of options when we do different procedures and different steps in the cataract surgery. So it's nice to know what are the pros, the cons of each and every equipment we are using, or perhaps the technique we are using. So we'll begin with Dr. Akida Lal. She's going to be speaking on Zepto. And so I don't know how many of us have it, but I think Dr. Shika, have you used Zepto?
Yeah. She's talking about Zepto or
Zepto.
Zepto. Yeah, I've used
On colors.
Yeah, I've used Zepto in a couple of cases.
Yeah. So
Right.
over to you, Akida.
A very good afternoon to you all. And before I begin, I would like to thank Dr. Reena Sethi for giving me this opportunity to talk about Zepto. Zepto, basically what it is a precision pulse capsulotomy device. So I'll be showing you a video, first going through the basics of how it works and a few interesting cases that we have to share with you. Can we have the video? Can we have the laptop connection, please? Yeah. All right. So this is the precision pulse capsulotomy system. And as we know, capsulorhexis is the most important step of cataract surgery. And therefore, we here share our experience with this device called Zepto, manufactured by the Minosis company. Now, first, it consists of a hand sole, which is a very small console, which can be placed in the OR directly, and comes with a console as well as a handpiece. Now, in this handpiece, there is a plunger system. We can make it go forward, and the plunger is connected to a suction cup, which houses a nitinol ring. So, when we push it forward, it takes an oblong shape and becomes narrower, and then we can pull it back. So, once we are inside the eye, we pull it back, retract it back so that it assumes a circular shape, and then we can go ahead with our capsulorhexis. So, let's shift to the microscopic view here, and we are looking at our first case. This goes in easily with a 2.2 millimeter incision. I like to stain the capsule with trypan blue before going ahead with this device and inject a dispersive OVD. Then we have made it oblong and inserted it inside the eye, and then we retract the push rod back so that it assumes a circular shape. Then we have to apply this suction cup onto the anterior lens capsule, and when we see the movement of these water molecules, that's when we press the button on the console, which releases this electrical discharge and gives us a nice central 5.2 millimeter capsulorhexis. Now let's look at a few interesting cases here. So this is a patient who has mature intermittent cataract. We like to use this device for such cases. And we see here that as soon as we apply the vacuum, the iris starts getting sucked into the suction cup. And the iris does not get damaged, but somehow it has gotten inside the cup. We come out of the eye, and then we decide to inject viscoelastic to really push the iris back and to look at the margin of the capsulorhexis here. And we notice that we have an intact capsulorhexis, so it has managed to cut through, and we can safely proceed with phacoemulsification here. Then our third case is that again of a white intumescent mature cataract, and this patient has been planned for a toric IOL. So we try to put our device to the test in such cases, and what we see here is that we have had a part of the capsule which remains uncut. So we've had skip areas here, probably because of inadequate contact between the suction cup and the anterior lens capsule in this particular case. So we are using a combination of the rhexis forceps as well as scissors to take care of this tag so that we can proceed safely further. Our next case here is just a grade 2 cataract, and we are using the Zepto device in this patient. And once we have made the capsulotomy, we see that we have a nice intact capsule. But notice here carefully that as soon as we inject the fluid, as soon as the hydrodissection is initiated, there is an anterior capsular tear. Now this could be maybe because the bag was inflated once we released the vacuum and the fluid had been pushed into the bag. So it's a good tip to decompress a little. Now, fifth case here, the capsule is intact to begin with. We have had an intact capsular excess, but as soon as we start our chopping maneuvers, there is an anterior capsular tear during chopping. Even though the chopper has not hit the anterior capsular margin, just with the shearing forces, somehow the capsule has torn. And this is very interesting and rare, as we know that this device actually gives us a stronger excess than manual. Now, this is a patient who is on an RK surgery about 20 years ago, and now he has this calcified capsule and a small pupil. So we know calcified capsule is very difficult to tackle just with a manual rhexis. So we decide to put this device to test over here. And what we notice it that even though this device cuts the capsule on top, but it is unable to cleave through this fibrotic area. So we are just using a combination of micro scissors and micro forceps to take care of this fibrotic part of the capsule, and then proceed with the surgery after inserting the malucin ring to take care of the small pupil. We insert the IOL in the eye, and then we are further trimming down this fibrotic plaque once we have safely done the surgery and inserted the IOL in the bag. So we have learned from this case now, and we have proposed with another case here with a similar case where we have this kind of a calcified capsule. So what we do here is we modify our technique and we plan an eccentric capsulorhexis, an intentionally eccentric capsulorhexis, so that all of this capsule which is calcified comes within the suction cup, so that it cleaves throughout, and we are able to achieve a good rhexis here. So we can see that we did not have to cut through with the micro scissors or micro forceps in this particular case, and we could safely go ahead with the phacoemulsification part of it. This is the IOL in place, of course a little eccentric but safer. Now we have this intumescent white cataract, and as we use this device very frequently in intumescent cataracts because to avoid this Argentinian flag sign, and we've actually had this issue that I'm going to demonstrate here in 2 patients. So what happens here is that we are unable to release the suction. So we have cut the capsule and we are pressing the suction continuously on the console, but somehow the capsule has gotten stuck to the lens and we are unable to release it. And the other case also in which we experienced this was again an intumescent cataract. So probably because of the fluid present, it sort of just gets sucked in. So finally I had to take my dumbbell dialer underneath this capsule to release the suction, and then we could pull this device out of the eye. And then the rest of the case proceeded as routine. Now this patient, what happens here is that as soon as we apply the suction, the anterior capsule gives away. So this is again an intumescent cataract, a lot of fluid inside, and although this tearing is limited within, but as soon as we start withdrawing the probe, we can see that it further tears, and there we've had a runaway rhexis, almost not completely like an Argentinian flag sign, but on one side it has run away. And we notice that the posterior capsule is intact, there is no posterior capsular extension, and we can complete the case with ease. So here are just a few salient points that we would like to share, the experience that we have had with this device. To conclude, this system is specially safe and gives us a precise capsulotomy, useful for premium IOL surgeries, intumescent cataracts, patients with corneal opacities, small pupils, and even calcified cataracts. So it comes in handy for all of these cases. We need to understand that we can still have complications, and we need to be mentally prepared for these, including a complete capsulorhexis or even anterior capsular tears while using this device. A few of the important points is that sometimes if the too much fluid gushes out, we can have an overinflation of the bag, although this is very rare. One of the cases that I demonstrated had an anterior capsular tear, so maybe just gentle hydrodissection or decompression would come in handy. Intumescent cataracts, we might have very rarely cases like this where we have difficulty in releasing vacuum, or we might still encounter a runaway rhexis, not probably like an Argentinian flag sign. So thank you so much for your attention. Thank you, ma'am, for inviting me to this course.
Thank you very much, Dr. Ekita. Now, to have a little conversation on this, a little debate, do you do flax as well?
Ma'am, we don't have flax in our center, so yes, I'm not very well versed with flax.
So with flax, people, they earlier on they were thinking of the lines of that, it's not a very strong rhexis that you have.
Yes.
But then since it's been devised and better technology has come in, so still, if we have to compare, what would your take-home message will be like?
So
Would you rely
Yes.
more on the Zepto or yeah?
So flax is flax. The problem with flax is to have a separate operating room to maintain the temperature and the humidity profile. We can't keep it in the OR. That's one. The expense that it adds to your surgical cost is huge, and the further expense to the patients. Secondly, the capsulorhexis that it creates is not as strong actually as the Zepto capsulorhexis, and this has been demonstrated in various animal models that this rhexis is actually 4 to 5 times stronger and has more shear forces that are required to actually rupture it than a rhexis that is created with flax. The advantage that flax would probably have is that it can also help you a little bit with the nucleus management, which the Zepto device currently cannot do.
Absolutely.
So that would be my take on it, ma'am.
And this would be one. And exactly like, what about subluxated lenses? Do you think?
Yeah. So it does work in subluxated lenses. I have used it in 2 patients, but not with gross subluxations, maybe less 3 clock hours, because you do not want to put in so much of a vacuum when you have a grossly subluxated IOL, because just with the sheer vacuum, you might disturb the lens nodules further. And it seems to work well. Even flax seems to work well in subluxated cataracts.
Yeah.
So I'm not sure. I don't know if we have the comparison enough cases to compare flax versus Zepto in subluxated cataracts. But both seem to work well, because it's difficult to do a manual rhexis when the lens is subluxated.
Thank you very much. Thank you. Any questions, Shikha?
So, how do you've compared it with flax? How do you compare it with your routine manual
Yes.
capsulorhexis?
Yes, ma'am. So, quite frankly, just to share my opinion here. If you have a routine case where there is no intumescence, it's not a patient with a corneal opacity or a fibrotic capsule, I feel for routine cases, manual rhexis in experienced hands, of course, works as well as flax, as well as precision pulse capsulotomy device. I do feel that for routine cases, all the techniques work very well, and there are studies published on it as well. There are comparison studies which are published, and it has been shown that the centration of the IOL and all these parameters are very comparable with all these 3 techniques. I think it comes in handy only for these couple of cases that I demonstrated, for intumescent cataracts, for calcified capsules, maybe even for small pupils. Small pupils, now we have excellent pupil expanding devices, which we can use and then proceed normally with the
So
rhexis.
you've shown quite a number of videos. You
Yes.
seem to have quite a bit of experience. See, anything at which you've worked at, you've done repeatedly, is bound to give results.
Yes, ma'am.
And you seem to have worked with this device in complicated cases
Yes,
quite a bit. And you personally feel that it gives you better results than what you would have done manually if you didn't have this device. Just want your opinion.
Just for like I said, just the cases that we have highlighted, like if you want to implant a premium IOL in a patient with an intumescent cataract, if you're going for a multifocal or a toric in such complicated cases with a fibrotic capsule, then I think it's a nice tool to have. But of course, there's nothing that can replace the surgical skill that you have. You can still do a wonderful capsular
No, I'm
rhexis.
asking you.
Yeah.
You've used this device.
Yes.
And if you're going to plan a premium IOL
Yes.
and there's a little bit of complication, you're going to go with this.
Yes,
you're going
absolutely.
to trust it.
Yes,
I
I'm
want
going to
your
trust.
opinion since
Yes,
you've
yes.
used it.
Yes, absolutely. If I have a white intumescent cataract and I'm planning like a multifocal IOL, absolutely. I tell my patients, we in fact have a counseling protocol at our place that if we have a intumescent cataract, they are informed that it is a better technique for you, and I would definitely go ahead with it. I trust the device. It works really well. The cases that I've shown are not the routine cases. These are one-off cases that we have collected over a period of years.
Yeah.
And so we have had these kind of issues and complications, and I just wanted to demonstrate that. But 95% of the times the case goes in very smoothly and there is no issue whatsoever with the device.
Thank you so much. Thanks. Thank you. So I'll just call upon Dr. Aditya Sethi, and he's going to be talking about little folks that need special strokes, managing pediatric cataract challenges.
Thank you so much. All right. So I'll be showing a video which basically comprises of the whole talk, but I'll be talking while the video plays. It's about little strokes. Can we get audio? Do we have audio? So since we're talking about pediatric cataract, Dr. Aikida, I would love to know if there's any experience with Zepto with pediatric, because they were coming up with a new ring.
So they're supposed to come up with a new So I don't have any personal experience yet with the pediatric cataract cases. I have not used it, but they are coming up with another size of the capsulotomy that probably they are going to come up with a 4.9 millimeter, which would be useful for pediatric cases and even for a posterior capsulotomy. So hopefully in future they are also working on the design to make it more ergonomic and sleeker. It's a little bulky at this point of time.
It makes sense with posterior also. It makes
Yes,
much.
exactly.
No, but with the posterior, don't you think the vacuum would be too great to just disrupt your
vitreous space?
Yeah.
So I have not used it. Let's see now if they, with the further modifications of the design, whether we are able to use it or not is a question which time will answer. The vacuum might be too much to suck in the vitreous. I'm not sure if it will work.
We saw the way the iris was getting sucked in,
Yes.
so obviously it has
Yeah,
quite a bit.
Alright. Okay, so let's talk about little folks. So we know all about pediatric cataracts, and since we're talking about both sides of the coin, we should talk about how pediatric cataract is so easy. At the same time, we should talk about how it can get so difficult. So these are some points that I would like to share that make pediatric cataracts, even the most difficult ones, slightly easier. So I hope I'll show you both sides of the coin. So often we find this sort of a cataract very easy to do, but sometimes in your OPD you can get this. So what do you do to those? So I like to start with always the basics, because if you in pediatric cataracts, to get a safe surgery, it's very, very, very important to have a chat with your anesthesiologist and get your general anesthesia right. It's recommended that you intubate these patients because we've seen that the eye gel or the LMA often pushes the posterior capsule a little higher and PCO2 levels are a little higher in these patients, and that can cause your vitreous to come in. Also, remember it's GA, so your head positioned once will remain like that. So keep that pupil dilated. I think the most important part is to get a good visualization, and if your pupil is well dilated, that works. But sometimes you can have this sort of a situation where the pupil is all stuck, and the reason could be some iris cyst, or you can have a complicated pediatric cataract with uveitis where you need to mechanically stretch it and sometimes even use pupil expander devices to get a better visualization. You can also have microphthalmia where you can't use expanded devices because there's no space. In those cases, just mechanical dilatation also helps you to get good visualization and hopefully not reach the bad side of the coin. So stain the capsule wherever possible. Pediatric cataracts don't perform like the adult cataract, and the shearing and tearing forces are very different in this. We all know about that, but it's very important to stain the capsule so that you can recover if there's an issue. Anterior rhexis, like I spoke about, you can either use forceps. Nowadays, even side port forceps or microrhexis forceps work beautifully. Initially, we were using retinal forceps to do this step. My personal favorite, though, is still the Uttarata forceps after I make a nick in these cases. And in certain cases, you have to be innovative and just stab it and then go ahead and do a nice vitrorhexis if required. Like if you have a plaque like this, which may have manual removal may be required. Dr. Ken Nischel also described the push and pull technique, which works very well under 2 years of age. In this, he makes 2 stabs opposite by 180 degrees, and one pushes, the other one pulls, and it completes a nice round rhexis very easily. You can also have situations like this where there's a nice large plaque and you may have to go all around it, or you may innovate and do a half and half rhexis where you can do a semi rhexis from one side, like very carefully, and then complete it by making another nick and doing a semi rhexis from the other side. This completes a nice round rhexis, and you can continue with your surgery. So lens aspiration, my mentors Dr. Ken Nischel and Dr. Kekunia love to show this, that like the Karate Kid, always go from the periphery to the center. That way, if you have ever a complicated pediatric cataract, you perform the same step and don't have this sort of a situation where you can have an open posterior capsule. Posterior capsulorhexis is one of the most dreaded steps for general ophthalmologists. In this, all you can do is take a small nick and use a high density viscoelastic, push it into a Burgess space to get a nice control and do a round rhexis. Anterior vitrectomy, most important step, because you don't want to do all that effort and then find out amblyopia still exists because there's posterior capsular opacification. So always do a nice anterior vitrectomy. Go under the margins of your posterior capsular rexes and make sure that they fall back and a round posterior capsule is there by the end of it. You can also use triamcinolone diluted form to check if there's any vitreous that you may be missing out on, or even simple, just use a dialer and go around the anterior chamber. IOL insertion technique, always fill the bag, because now you've got a posterior capsular opening and an anterior capsular opening, and like an aeroplane lands, that's how your IOL should also. So always pull up and in the last moment dip down and then place the IOL inside the bag. 3-piece IOLs also have their own challenges. Can be put through an injector or a holding folding way, depends on your preference and choice. Nowadays we also have preloaded 3-piece IOLs from an Indian company, works very well. Traumatic pediatric cataracts come with their own set of problems, like an open posterior capsule, which can be there in your case, and in this case it was lucky, no issues. But always remember, not every trauma acts the same, and sometimes you can just have this sort of an episode where you think everything is going well, and you go around and then suddenly the rexus is running out, then you're pulling it out, and then you suddenly realize that something may not be there. You can see a little bit of vitreous around there. So you go ahead with your vitrector and you try to take whatever you can, periphery first of course, and then by the time you think you're doing very well, and it just drops. So always have a vitreoretinal friend or a relative, in my case, always works very well in these conditions, because general anesthesia, you don't want them to be going back with a lens inside the vitreous cavity. Traumatic pediatric cataracts can also present with very poor dilatation and a corneal scar. Very important to be thorough in these cases. Do a routine cataract surgery wherever possible and place a IOL in the bag. So plan for a secondary IOL. This is something that we should all do as pediatric cataracts when in doubt, because you don't want to put in a IOL in a place where IOL should not be there. Like in this case of PHPV, which is very vascular. We ended up doing a lensectomy, and then we planned for a secondary IOL on a later date. This is a microspherophakia. So in this case also, because there was no support, we planned to do a secondary IOL in the later stage. Sometimes when you're not concentrating, or there's a sudden gush, you can make a posterior capsular opening or an iatrogenic break, but don't lose your cool. Make it into a PPC and then continue your cataract surgery as you would want to. The advantage of being comfortable with a PPC. You can always place a single piece IOL in the bag. Always preferred choice is in the bag, single piece IOL whenever possible. This is another case of, if you notice there's a valve there, it's an aniridia case where there's a valve which is causing the cataract because it's touching the lens. In these cases you have to be a little more innovative, go around it, maybe even open the valve for the glaucoma surgeon so they're happy with you. And then it's a routine cataract surgery. Thank you so much. I hope I was able to show you both sides of the coin.
Thank you very much, Dr. Aditya. Very well, a lot of good videos and well presented. Any questions, Dr. Shikha?
Aditya, you showed that you've used intravitreal triamcinolone for doing vitrectomy. Yes. So in children, I'm just curious that how do you monitor the IOP and all later on? I mean, like, it's safe. What's the safety profile of this in children?
So, ma'am, not routinely. We don't use triamcinolone routinely, but it's a good method of checking, especially for people who don't do PPCs and anterior vitrectomies all the time. It's fairly safe. We do keep them on acetazolamide if required, but that's generally with IV acetazolamide is what's suggested. But I haven't had a reason to start that yet, so it's.
Do you think it's okay?
Yeah, it's okay.
I think most of it comes out also with the
Yes.
vitrectomy, a little bit doing whatever you're doing.
But
yeah.
like in that video, it went into the vitreous cavity, so that also happened, and that's more or less okay. Helps with the inflammation also later.
So, any other takes you'd like to give the audience about pediatric cataracts?
Pediatric cataracts are ever evolving. But you have to. So often we do feel that following the basic structure of the pediatric cataract surgery works very well, but we have to often innovate inside the OT, especially in special situations like you will have a traumatic cataract or any other reason where the lens may not be there. So I think the most important part is you shouldn't have an ego as a surgeon, because often you may not put a lens, and that may irk a lot of anterior segment surgeons. But in this case, you're doing it for the benefit of the patient, because later on you can put a better lens in a better placed position, and that can go on for years and years. So this patient is not only your patient for next 40 years, he's your patient for next 80 years. So you have to view it as a long-term situation.
So I think that one critical step in every pediatric cataract is your capsular rhexis, because I think if you've done that, you've done more than half your job.
Yes.
Because the phaco part is basically an IA only and very easy to do. Like Aditya showed, it's a good idea to do it from the periphery and keep taking do a very sequential cleaning of the lens, aspiration, do only that. Don't use your phaco probe. And I think making the right choice of the lens is another second very important part in these cases.
Yeah.
Thank you
And
very much.
getting your IOL calculation biometry right
Absolutely.
also.
Yeah.
Thank you.
Thank you so much.
Thank you.
So I'm going to now invite Dr. Shikha. She is going to be speaking on posterior polar cataracts, and she's going to give her views on how to handle these cases.
Good evening, everyone. At the outset, I would like to thank Dr. Reena for giving me this opportunity to talk about management of posterior polar cataract. So, posterior polar cataract is a congenital cataract which has increased incidence of posterior capsular rent. In a normal cataract, this incidence is less than 1%. In case of PPC, this incidence is increased to 6 to 36%. Why? Because of the adherence of the cellular opacity to the capsule, as well as because of the extreme thinning and fragility of the posterior capsule. This condition is fairly common, seen in 3 to 5 in every 1,000 individuals, and it's mostly bilateral. Around in 80% of cases, it's bilateral, and there's a positive family history in half of the patients. So we can see here that as the technology and the techniques have advanced, the incidence of PCR, posterior capsular rent, in PPC has decreased. And we did a study at Shankar Nethralaya where we studied the incidence of PCR in over 2 eras, from 2006 to 10, one group, and 16 to 20. And we also noticed that the incidence of PCR indeed has come down because of the advancements in the technology and development of newer techniques. Now, among the technologies, I think the anterior segment OCT has played an important role. You can literally look at the posterior capsular integrity. So this paper by Chan et al. Says that the posterior, they have studied the PPC in 37 eyes, and they've graded the PPC on ASOCT, anterior segment OCT, and the grade 3 is absence of intact PC. So you can literally see that the PC is not there and prepare yourself for those cases. Another very interesting study from PGI, they studied around 58 eyes of PPC, out of which 9 eyes had a rent, PCR. And what they noticed is that in eyes with PPC larger than 4 millimeter in size, the incidence of PCR was 30%. And eyes with PPC less than 4 millimeter in size, the incidence of PCR was 5.7%. I think that this is an important clue, to predict if you don't have ASOCT. Now we look at some of the videos and we look at the steps, of surgery, phacoemulsification, and PPC. So you need an adequate size of capsular rhexis. The rhexis should neither be too large so that you are not able to do an optic capture in case you have a rent, nor should it be very small. If it is very small, you won't be able to take out the pieces of the divided nucleus. Hydrodissection is contraindicated in these cases, and hydrodelineation can be done. In this video, I have neither done the hydrodissection nor done the hydrodelineation, have started directly with trenching. So you can trench, though this is a fast forward video, but you're supposed to do a slow motion phaco where you use low phaco, low flow rate and low vacuum. And after that, the division is done without rotating the nucleus or the epinucleus. And here, even the pieces are brought out without rotating. You have to rotate the tip in such a way that you can bring the pieces out in case you're planning to divide the nucleus and take it out. Similarly, the other side nucleus can be removed the same way. Now, what is important here is that the anterior chamber stability should be maintained at all cost. So when you're removing the instrument, inject viscoelastic so that the posterior capsule neither moves anteriorly nor posteriorly. So when I remove my instruments, the anterior chamber is formed. This is a very important step. Now I am left with a bit of epinucleus and a lot of cortex. So these steps are the most important steps. So the cortical cleanup, as said in the previous talk also, should be done from the fornices, from the capsular fornices, and you leave the center attached here. Clear the fornices first and leave the central cortex attached. That should be, because as we've seen previously, it is very adherent to the posterior capsule, the cortex there. So if you try to peel it in the beginning, till you feel the things are under control, don't remove the central cortex. So another thing that you'll notice here is that I'm using a bimanual irrigation aspiration. So I haven't switched hands. Usually to clear the other side cortex, you will switch hands. In doing so, again, you're going to destabilize the anterior chamber. So if you have the expertise, do it off in one go. Alternatively, you can use a coaxial irrigation aspiration where you don't have to repeatedly come in and out of the anterior chamber. Posterior capsular PC polishing should not be done because the PC is very thin in these cases, and hence what I've done here is I've cleared it with the posterior part of the cannula, that is the aspiration cannula. Again, the anterior chamber is formed with the viscoelastic, and the lens, ideally, you can have a rent at any stage of PPC surgery. We can't be complacent that, the lens material is out. I've had rents while putting the lens. So ideally, a lens that in which you require least manipulation. A single piece foldable lens is usually easily put in the bag, and that's what I feel should be the choice of IOL in these cases. So this we have seen that when you're able to divide the nucleus, at times, now let's look at another case when we are not able to divide the nucleus. Sometimes, the nucleus is, especially when you try to do it in early cases, it's like a jelly kind of a thing which doesn't really separate. I've got a crack, but it's not separated. It's not coming out as a single piece. So I know that I'm not going to be able to lift up this half of the nucleus. So I'm going to change the strategy. And how did I change the strategy? I just started chipping. Now, instead of playing in the vertical plane, I am removing the horizontal, that is the inferior half of the nucleus, and I'm creating space. So chip off whatever safely, whatever bits of nucleus you can, and then you have a lot of space. After that, the most important step, that is the viscodissection. So inject viscoelastic underneath the capsular margin and lift up the, it's very easy, believe you me, to once the inferior nucleus is out, it's very easy. You just inject viscoelastic underneath the superior capsule, and the superior half of the nucleus will come up. And thereafter, it's the same thing, that you start cleaning the periphery first, and then in the last you clear the center part. So when we analyzed our results of incidence of PCR in PPC in different stages of cataract surgery, we found that cortical wash in this step, it's the highest incidence. Around 60% of rents we noticed occur during cortical wash. So as I said previously, this is a step where you need to tread really carefully. So followed by, so PCR can occur at any stage. Commonest is cortical wash, followed by nuclear emulsification. Usually it is thought, that chances of nucleus drop and all are high, but it's usually the rent occurs after the nucleus is out. This is what our study results showed. So in conclusion, we require an adequate size CCC, minimal hydrodissection, and hydro procedures, if at all can be avoided, should be avoided, and should try to maintain a stable anterior chamber, and should do a slow motion phaco, that is, use all the parameters, keep them a little low. And anybody trying to do phacoemulsification in PPC should learn viscodissection, should be adept at viscodissection. It will help you in moving out the nucleus, help in epinucleus, as well as in cortex. Thank you.
Very nice presentation, Dr. Shikha. Any any tips you like to give for your viscodissection? Like how much are you using, and do you do a multi-quadrant thing,
Yes.
or just one end only you lift it up?
Yeah, so it's you can do it. Usually you need, before you do that, you need a little bit of space. That is what is important. So you should have, as I said, for the nucleus, basically, the whole of nucleus will not come out unless it's really soft, and you're doing kind of viscodelineation kind of thing in softer nucleus. But if it's a little formed nucleus, then you need to clear out a bit of area and inject visco. It's just like doing a hydro. You're just using a cannula and removing it.
So now what I'm trying to say is that you don't want too much of visco also to go like as a gushing inside also, because it'll be the same thing. Like we are avoiding hydrodissection, we're doing more of a delineation. So if we could just put the visco like just to lift up the edge, wouldn't that be enough?
So I don't think so. It goes the same way. The visco doesn't behave like the hydro. It does not. It's a little more viscous. So I've not faced that problem. I don't know if somebody else injects too forcefully, but that has not been. That's not my concern.
Okay. Thank you so much. Thank you. So our next speaker is Dr. Chitra Ramurthy, and she's going to be discussing debates about, keratoconus and corneal ectasias and toric IOLs.
Can you hear me? Very good afternoon to... Isko band kar rahe the. Very good afternoon to one and all of you, and mind you, in the next few minutes is to talk on toric IOLs in keratoconus and other corneal ectasia. Where would you indulge? Now, how is it that a toric IOL placement in these ectatic conditions need a special mention is what I'm going to take you on. The most important thing is the pre-operative considerations are very critical if you want to optimize the outcome in cataract surgery in keratoconic eyes. Now, what are the indications when you would implant a toric IOL in a case of KC? It's not coming there? If it is a mild to moderate keratoconus, you can consider. If it is a non-progressive disease, now more likely a cataract in that age group, there would have been enough natural cross-linking, so KC is less likely to be there. And these patients, if they are not dependent on a rigid contact lens to achieve a good visual acuity, it gives us a feeling that there is a likelihood of the astigmatism not being too irregular. We should also have an historical data that these patients before the inception of cataract had a good decent vision, and astigmatism that is not very irregular in the central 4 millimeter of cornea, and there is also a possibility that it's just a mild to moderate, that they may be fine, they may not need a corneal transplant, and if it has, or if a PKP has done, they should have regular astigmatism. These are the indications. When would you not do a cataract surgery, toric IOL in a KC? If it is an advanced KC, and more though if it has a central scar because of eye drops, or if it is a young patient with a progressive keratoconus where because the cornea is still elastic and there's still ectasia to progress could happen, then it becomes crazy for us to get measurements because it is going to change in every axis and meridian. And of course, if a graft is being considered in future, then you would not implant a toric IOL. Again, whether would you plan if it is a centered or a decentered cone? In a centered cone, the chances that you would have put a toric IOL is more, but in a decentered cone, we need to know what is the extent of decentration and what is the irregularity in the central 3 to 4 millimeters. Again, if he is not a previous RGP or a rose scale lens user, and even if they have been wearing lenses, you need to remove their lenses and ensure there's a repeatability in the K values, and then only you go ahead and do the IOL power calculation. And if it is a little irregular cornea and you're able to talk to the patient and convince him to do a topo-guided PRK to regularize the cornea, or if you can do an intact segment, and following that doing a cataract surgery would be a very ideal way to go. Now we have the different topographers, the tomographers, the Shamefunk device, the swept source OCT. So with all these devices, we are now able to identify keratoconus in nearly 5 to 10 times more than what we could identify before. And again, in this, we need to see whether the central 3 to 4 millimeters is not irregular. But if there is a steepening of the cornea far away from the central area, you could still implant a KC like in a pellucid marginal degeneration. Now, if a patient is a previous RGP or a low scale lens wearer, if it's a RGP lens, 2 to 3 weeks, they have to be off contact lenses. If they have been wearing soft contact lenses, 1 week. But if it is clearer lens, just 2 days off contact lenses is also all right for you to get fairly repeatable readings. But then, if they have been constantly wearing RGP lenses and they are only comfortable with that, probably it is best to do a non-toric monofocal IOL, because these patients, that means they have a significant irregular astigmatism, and by just doing a cataract surgery, you cannot presume that they will not need a contact lens wear. And I'll explain to you what would happen if you go back to wearing lenses after you've done a toric IOL. Again, repeatability in K measurements is a challenge. There could be a tear film abnormality in these corneas. So we need to regularize all of this. I mean, make the tear film more smoother and more to get repeatable measurements. Then what happens if you are going to use standard IOL formulas? Now, the reason why the challenge is here is the ratio of the anterior to the posterior surface of the cornea, the ratio gets altered because along with the steepening of the anterior cornea, the posterior cornea is also getting steeper. So the normal refractive index of 1.3325 gets altered in these cases. So what happens is, if you are going to calculate the total corneal power in a pentacam or a total corneal net corneal power on a pentacam, and use these values into the earlier generation formula, it will not do well because they have a different keratometric index, and what has happened to the corneal index, keratoconus index, has changed. Again, the other important thing is what happens in these eyes is the cornea is also has become steep. So the anterior chamber becomes very deep. So where the lens is going to sit is actually more posterior than it is going to be in these normal eyes. So even the effective lens position gets altered. So what happens then? What can happen is they could end up with little more of hyperopia after a cataract surgery, because not only have they an AC depth which is irregular, many of these eyes are myopic. So even in myopic eyes, you could end up with an overestimation and a hyperopic end result. So what has also been seen is if it is a mild keratoconus, the hyperopic error is lower, and naturally, and if the keratoconus is severe, the end hyperopic outcome is more. Also, in these ocular keratoconic eyes, the inflammatory markers are more because the tear film regularity is more, and that itself can impact the K readings. Now, when it comes to doing the K readings, if your standard deviation is more than 2, that it's an indicator that you have to repeat your measurements. But even after repeated measurements, your standard deviation continues to be more, then what you should do is you should take the lowest value of K reading so that it ends to a little myopic outcome, because there's a greater challenge of ending up with a hyperopia. So you should try to avoid selecting a low power. Then the other important thing is, again, if the patient has been wearing a hard contact lens, clearer lenses, K readings we are not able to get it, try to aim for a little myopic target in your IOL power calculation. Now, as far as what happens to the posterior cornea, the posterior corneal astigmatism is contributing to the toric IOL power. But what happens in these eyes is, instead of the routinely being an against the rule astigmatism, here there is more likelihood of the posterior cornea to have a with the rule astigmatism. And again, as it was said, that you will find that it is better to follow the EKR value in your IOL power calculation than to go by the total net corneal power which is available on the IOL master or the pentacam, because they have a different refractive index. As far as the choice of IOL formula is concerned, therein itself is a great inaccuracy. Rather, the SRKT, surprisingly, was fairly consistent, and so earlier on, people used to use the SRKT formula for keratoconus because it used to assume that the cornea is more steeper and used to err towards a myopic outcome. Now, that is what we want in a KC, because you can get a hyperopic surprise. The Kane formula has also gained a lot of popularity, but in Kane formula, you don't feed in the total corneal power. You feed in the anterior corneal power into the Kane's formula, and then it would calculate the IOL power. And it is said that what they recommend is that if the astigmatism is stage 1, you do not alter the IOL power, but you aim for 0.7 to 1.5 diopter myopia as the end result. In moderate keratoconus and severe keratoconus, you try to leave the eye with -2 to -3 diopter keratoconus. And this graph tells us that the Kane's formula is doing pretty well and nearly as good as the Barrett formula which is available for the keratoconus, and you'll find that the SRKT is also coming close behind. Again, the Barrett-Truquet formula for keratoconus is available on the APCRS website. Herein again, you have to feed in the anterior corneal power and allow the Barrett-Truquet to predict the total corneal power. And again, different measurements have said that the Kane's formula, the SRKT and the Barrett's seem to be similar. So as far as the timing of the surgery, based on the kind of vision the patient has, you would do a topography, and based on the topography, you would decide whether you are going to put a toric IOL in this patient or you are going to put a monofocal IOL. And if the corneal surface is irregular, then you would decide whether you would do a topo-guided PRK intact and then go on to taking your IOL part. Now, this is just an example of a decentered cone, as you can see there. And after regularizing the topography, the central 3 millimeters is more regular and you can do a cataract surgery. Again here, again it's a decentered cone, and following an intact segment, the central cornea has become more regular and you are able to do a cataract surgery. When it comes to doing a cataract surgery, The intacts are largely in the 6.8 to 7.6 optic zone. So you can easily create a 4.9 millimeter capsulotomy on a femto cataract platform, in the sense that capsular excess is not going to come in the area of intacts. So you will not have any areas of uncut rexes. The other important thing is sometimes these corneas can be so steep that you have to use a Trifen blue that will help you to pick up the rexes better, or you could even leave viscoelastic on the cornea. Sometimes people even place an RGP lens, viscoelastic on the cornea, methyl cellulose, and place an RGP lens, and then they get a better visualization to do a cataract surgery in these eyes. With the PMD, there's less irregularity in the central cornea, so all you have to do is plan a customized toric IOL. Again, post DALC or a PK, you need to wait till you are able to remove all the sutures, see whether you are getting repeatable topography and K readings, and you still understand that your aim is not emetropia, but you can go ahead and put a customized toric IOL. I'm just going to show one of these surgeries, like how you wait for the sutures to be removed, you make your incision beyond the graft, or sometimes you could make a scleral incision. You need to ensure there's enough viscoelastic to coat the undersurface to protect the endothelium, keep your parameters low. These could be highly myopic eyes, so you have to keep your IOP ramp a little higher, go in with the infusion, zero infusion, because there could be a reverse pupillary block which can occur in these eyes. And then, of course, do a good posterior capsular polishing and place the lens in these eyes. I'm not showing you this, which is all very similar. Rarely, you might have a refractive surprise, then you may have to do an IOL exchange or a piggyback IOL, but you need to have counseled your patient adequately. So I would like to summarize stating that you need to account for the posterior corneal power. You know that the formulas which work best are the Keynes formula or the Barrett formula for keratoconus or an SRKT if you don't have access to these. And you should look at the corneal power map before doing a topography. And why, if you have placed an if the patient, you've done a cataract surgery and he's not very happy with the vision, he wants to go back to wearing RGP lenses, and you have already implanted a toric IOL in these eyes, then you need to give a spectacle correction which will neutralize the toric IOL power inside. You understand? Because placing a contact lens on the cornea, it is correcting the corneal astigmatism, but the toric IOL is sitting there. So you need to give a spectacle correction which will neutralize the toric IOL power inside. That is why people who are very much on RGP lenses are not the ideal patient to put a toric IOL. They may be better off with a monofocal, and they can continue to wear toric IOL in the later years. I know what I said was a whole lot of complicated stuff, but I hope there was one or two take-home messages from this for all of you.
Yeah.
Thank you.
Thank you very much. I think if we would just say a couple of things,
Yeah.
I think counseling was very, very important, because
Yeah.
the patient will be very dissatisfied.
Counseling is very important.
Yeah.
Your IOL power calculations can go a little haywire. You might end up with a little hyperopia. So you try to leave a little myopic outcome and choose either an SRKT, Keynes formula and Barrett formula for keratoconus, which will be there on APACRS website or ASCRS website. So these are the three main things. And of course, surgery has to be done carefully and assume them to be myopic eyes. Keep your IOP low, because the rigidity of the cornea and the sclera is less in these eyes. So do a slow motion phacoemulsification.
And these patients also have some of them have the RGP lenses. That also gives us a little clue about the K readings also.
No, if they are wearing RGP lenses and they say they are only happy with the RGP lenses, you know that they have a more irregular astigmatism on the cornea. So that itself is an indication that these patients may not do well with a toric IOL.
Yeah.
So you might as well do a regular cataract surgery, put a monofocal IOL.
Correct. Thank you very much, Dr. Chitra. Thank you. So our next speaker is Dr. Sahiba, and she's going to be talking about the mix and the MIGs, simplifying the complicated.
Thank you so much for the opportunity. So my topic for today is combining cataract surgery with MIGs, and we'll understand over the course of next few slides why that's important. So where is MIGs indicated to begin with? It's very important to understand. These are patients with mild to moderate open angle glaucomas who are anyway going to undergo cataract surgery and are on 2 or more anti-glaucoma medications with a widely open angle, specifically those who are having trouble with their anti-glaucoma medications from the perspective of side effects or compliance issues, etc. The options available to us in India are bent ab interno needle goniotomy, gonioscopic assisted transluminal trabeculotomy, the iStent implants, trabectome, and Kahug dual blade. The aim of mixed procedure is to reduce the intraocular pressure or the anti-glaucoma medication burden when combined with phacoemulsification for glaucoma patients. And time and again, studies have proved that clinical outcomes compared to phaco alone or phaco with MIGS is much more substantial. So let's look at this case of a young patient who had mild glaucoma with a VFI of 92% and IOP of 16 on 4 anti-glaucoma medications. Very difficult for him to take the medications because of side effects as well as his busy routine. Now, a few years earlier, we could have only given him the option of TRAB, which is also not free of complications. But now we do have a new surgical technique, MIGS, in our surgical armamentarium to offer to him. So he underwent a cataract surgery for a developmental cataract, followed by the iStent inject implantation, and is doing well. Let's look at another case of a 62-year-old female who underwent phacotrab in one eye and is very aware of the nuances associated with trabeculectomy. So in the other eye, the patient had a mild glaucoma with an IOP of 25, 5 anti-glaucoma medications, and posterior subcapsular cataract. So what would you choose in this patient? Would you do a TRAB for just a less than 10 millimeters mmHg of drop in this patient with such a mild glaucoma? Would you continue the patient on 5 AGMs and just do a cataract surgery? Or are you expecting that the IOP will drop with just the phaco alone? So I prefer combining MIGS in these patients because they are ideal mild to moderate open angle glaucomas who are anyway undergoing phacoemulsification. So this patient underwent a bank procedure which is followed by the cataract surgery. Now, again, another argument could be, does phaco not reduce intraocular pressure? Well, let's remember that it does, only to an extent of 1 to 4 millimeters of mercury, and that effect also diminishes over time. And patients who are on maximum medications have no effect of phaco on reducing their IOP post phaco. And one must also remember that phaco is a progressive disease. If you are subjecting a glaucoma patient to only phaco, there is a 45% chance they will have IOP spikes and they will end up with AGMs higher than what they started preoperatively. So what benefit am I providing the patient by reducing or stopping anti-glaucoma medications? I'm giving them better quality of life. Let's imagine putting drops 5 times a day for our own cells. It's not easy. Also, 50% of patients are non-compliant to the anti-glaucoma medications, and these are Indian studies. And the main reason cited is forgetfulness. So this is how casually our patients take it, and they only present when it is too late for the doctor to intervene. Better 24-hour IOP control, better visual field stability, reduced ocular surface toxicity, all these are advantages that we are offering patients when we are giving them the option of MIGS. And what do you lose? Well, really nothing, because what MIGS entails over and above the routine cataract surgery is just 15 minutes more of your time. You're using the same phaco incision, the same post-op regimen of drops. You have a much shorter recovery time, the same complication rate as you would see with phaco alone, and also you're giving them the advantage of sparing the conjunctiva for any future trabeculectomy if required. While the overhyped, the reason that overhyped reason why MIGS is not popular is cost, which is quoted. Well, even while using AGMs, a patient is using 7.7% per annum income of the family just in purchasing anti-glaucoma medications every month. And let's remember, this is a recurrent cost for the rest of their lives, vis-a-vis a one-time payment, which is also very well covered under insurance now. So in summary, while topical anti-glaucoma medications have a favorable safety profile, they have only a moderate success in lowering IOP, and it is dependent on adherence, which is as low as 50%. So MIGS has the potential of adequately reducing the intraocular pressure of patients who are undergoing cataract surgery in glaucoma. Thank you so much.
Thank you very much, Dr. Saiba. Dr. Saiba, can you tell us what is the follow-up of these patients, like when they get this combined procedure done? How long do you think the effectivity of the MIGS is going to be there? I mean, like, is there rather?
Okay, so now the follow-up protocol is first post-op day, 1 week, and then 1 month, and then 3 months. Of course, unless there is some other problems that you're expecting. Now, this follow-up also changes with different techniques of MIGS. You will have to have a more frequent follow-up when you're using less sophisticated methods like bang. And next comes KDB. The iStent implants are way more sophisticated, so that the post-op follow-ups and recovery is much faster. Now, as far as the effect of these things are concerned, Bang is unpopular for having developing PAS, which is peripheral anterior synechiae, very soon on in the course of the disease. KDB is a little more sophisticated because it has a cleaner cut of the trabecular meshwork. So again, and iStent, of course, we have published studies of as long as 5 years of doing well.
These patients, are you calling them for your regular glaucoma follow-ups as well? I mean, I'm assuming that it's just that one eye which needed the follow-up, like your the fields and all that. How often would you be doing it? Are you calling them once in 3 years or 2 years, or what is the
So yes,
protocol?
that protocol doesn't change. The follow-up is decided by the stage of the disease. So the mild, as long as this patient has achieved his target IOP, the follow-up will remain the same, which is about 6 months for a mild glaucoma patient. Moderate will be 3 to 6 months. Advanced will be every 3 months. Glaucoma is a progressive disease, irrespective of what intervention the patient has had, whether it's trab, tube, or MIGS, or even if the patient is on AGM, the follow-up regime stays the same according to the stage of the disease.
Good. Thank you so much.
Thank
Thank you very
you.
much. Thank you. So I think So I think I'm just giving the last talk, which is going to be on refractive surprises after a cataract surgery. What are going to be our options? So really, if you've done a good cataract surgery and yet your patients are not very happy, so there are going to be some culprits which have caused this refractive surprise, and that usually is the problem with these patients. There could be patients who had small eyes. They were hyperopes, extreme hyperopes, myopes, large axial lens. They had a dense white or a Brunison cataract where the low SNR was there for biometry, and it was giving you a false reading. And these also cases of post-radial keratotomy, PRK or LASIK patients where it's very difficult to really pinpoint what is going to be the IOL power. Any which way, you need to know what actually went wrong. Was it your biometry? Was it the incorrect formula that you use? Was there a problem with the data entry error, or was that not the right IOL that you implanted? And you need to see that whether you've correctly placed it in the bag and it wasn't upside down, which usually is rare though. And or if there is any other, retinal or posterior segment anomaly. So there are very tips and tricks. We must just go back to them. They are like need to do both the eyes together. You must see that there is no difference. And when you're doing, indentation of the cornea, compression should not be so much, because if you do that, then you are going to give it a bit of myopic shift to the patient. So a very good biometry is very important. See that there is no dry eye in the patients. If you feel that there is any dryness, call the patient once again after you've given all the supplements for dryness and all. Always measure both your eyes. Axial length difference between the two eyes should not be more than 0.3 millimeters. And give some, and any two consecutive readings should not be more than 0.2 millimeters. So all these things should be taken well into account. And we need to use the latest formulae, that is the Barrett's formula with universal 2 works for most of the patients. So, and if there is any refractive cases like post-LASIK or not, Barrett's 2K is what has to be used. So, toric calculations to predict cylindrical outcomes, we really need to have a good chair time with your patients. And whenever you're in planning your these lenses, just see that you have double checked your IOL, the IOL biometry details, the eye is marked, preoperative, intraoperative, post-op, all the three. The surgeon assistant as well as the OT in charge should read out the values so that you don't make any mistake. It should be in the back placement. Make sure there's no tilt of the IOL. Sometimes it's just, whenever we made a bigger capsular rhexis than required, one of the edges of the IOL just has a little bit of a tilt. So just before finishing your case, you must see that you just press your IOL properly, and then as much of a best cover that you can give on the margins, you should do that. So you should look for any other abnormalities. And what are the management? Now, if you have a patient like that, we have a couple of things that we can do. Either we just, if it's a minimum problem, we can just give the patient glasses. Contact lenses, we can do limpal incisions if you feel that there is some astigmatic problem in the patient now post-operatively, or a PRK LASIK, or an IOL exchange, or a piggyback IOL. So this is one of the cases in which we plan to do an IOL exchange. The various tips in this is that we need to give a good protection to the cornea. So give a good, use a good OVD, and gently you need to cleave the anterior capsule and the lens. So basically at the optic and the haptic junction is where you have the maximum amount of fibrosis, or that has to be released, and try doing this all around 360 degrees. Once you've done that, under good cover of viscoelastic, you need to just see that whether you can nudge the lens around. If you can nudge it, then with viscoelastic underneath the IOL, with a Lester's hook, you can just bring one of the haptics into the anterior chamber very gently. Each procedure has to be done very gently, because as and when you try to pull, you may just pull the bag as well. So just lift with lifting movements. Don't touch the endothelium. Put the viscoelastic repeatedly, and then once the one haptic is out, you can then nudge out the other haptic also into the anterior chamber. It's not very difficult. And doing a scaffold technique is what is always helpful, because this protects your posterior capsule. You put in the intended IOL, and under this lens only, you need to just tuck it in, put it in the right position. So a very gentle dialing into the bag is done. And now with the lens which is come out into the ones that has to be exchanged, which is in the anterior chamber, with a nice amount of viscoelastic protecting the endothelium, support it with your non-dominant hand, and then you can, with the scissors, you can just cut this into smaller bits, and you can take them out. There's another technique also in which you can hold it with in the center and near the optic haptic junction, and you can just twist your hand, and you can just rotate the lens over the forceps, and you can just take out the lens. But in my hands, I find this much easier to just cut it into smaller bits and take out the lens which has to be exchanged. Now, sometimes it's just the toric IOL which is not aligned properly. So you go back, calculate according to your toric correction, the Barrett's toric corrector, and then what you need to do is you need to remark the cornea, mark them again. And again, with viscoelastic, just dissect out all the fibrous material that is causing a roundabout, fibrosis around and unable to just move the lens. So then once this is all out and the anterior capsule is free of the fibers and all this fibroelastic part, then you need to just dial the lens back into the attempted direction and axis. And once you've done that, you can just take out the viscoelastic again, and your case is, the patient will be much happier once you've redialed the IOL. Sometimes it is just one of the haptics is not in the bag, so you need to put in more viscoelastic and redial it so that it goes into the bag, and then the problem which you were having of the refractive surprise is taken care. This is a case in which a piggy bag IOL was required. The patient had about a 3 diopter astigmatism. We got a lens ordered for this, especially. This is a piggy bag lens. This is how you need to. These are very, very thin lenses, easy to implant. They need to be just put into the cartridge carefully. See that all the 4 loops are there in. And you can inject it very gently after you've created the space with the viscoelastic, and that will take care, and then align it towards the axis that is required. And these lenses are behind the iris plane, and which you can just tuck in very gently. You'll see how they are being tucked in, and then the intended axis is attained here. So really the future is not very far off, I think. We're going to have better biometers. We'll have, which give you flawless biometry. And then we also are having, which we just saw at the ASCRS also recently, is the light adjusted lenses, which are getting very popular now. In that, what happens is that the lens is implanted, and up to 3 times we can polymerize this lens. It has fluid. So with the photo light, we can polymerize it and get the intended refraction for the patient. Thank you very much for your kind listening. I think now we can call off the session because there is no other speaker here. And thank you very much to all the audience. Thank you.